Okay, so Gary, you've become, I think, an expert in hip problems. And I'll be honest, my understanding of the hip is kind of limited. So I want to ask some basic questions I think a lot of patients may have as well. So what are common symptoms when a patient has a problem with their hip?
Common symptoms are pain, pain with activity, and sometimes positional pain. So a lot of times, kind of the most classic younger patient hip problem is like a labrum tear or FAI. That's probably one of the more common ones. And there's pain kind of deep in the groin, and especially as they sit or as they like squat down when their hip is flexed, when they're on a flight, that type of pain. It tends to be, achy most of the time, but then can be also sharp and stabbing. When you're talking about kind of a bursitis or maybe a gluteal tendinopathy pain, that's typically like I can't get to sleep because every time I lay on my side, it hurts right here over that spot. There's in an older population with hip arthritis that tends to act like the joint with anterior pain. So as I showed in the slide, the number of diagnoses for hip is so common. Mm-hmm. There's a study done that a patient has to see between 3 and 4 providers to get into the right slot or get the correct diagnosis, because there's so many different other things it can be that we have to rule out, and so many kind of less common causes of hip pain that pop up and that we actually see.
So simplify it for me just a little bit more. So what structures are involved in the hip? Mm-hmm. What bone?
So
you said labrum.
Yeah. So you have
what structures are there?
So from a bone standpoint, you have the acetabulum or the socket, and the femoral head or the ball. You also have cartilage that can be injured or damaged, kind of like any joint. You have a labrum, which is a cartilage ring that surrounds the socket and acts kind of as an additional stability factor. It kind of makes a suction seal with the hip. You also have numerous muscles that cross the hip joint, and then you have major tendons that, your gluteal tendons attached to the top of the hip that allow you to position your pelvis in space and walk.
So you really have to take into consideration all of these structures, mm-hmm. and which one of them, or multiple maybe, is causing the symptoms. You also have to make sure that it's a hip problem and not an SI joint problem,
sure.
or something coming from the spine or another structure. What do you do with physical exam to help differentiate those things?
So a lot of our physical exam is trying to recreate the pain that the patient has.
That sounds like a great visit to the doctor's office.
Yeah, absolutely. I think some of my patients are a little frustrated with me as they limp out the door.
You were supposed to help me.
Yeah, well, sometimes you have to hurt before you can help, I would say. So we try to recreate the pain. So for a cartilage or a hip arthritis or a labrum issue, we try to flex them up and rotate them in a position where we impinge it or we kind of stress it. And if we can recreate that groin pain with those movements, it's more likely an interarticular or a problem inside the joint. For the muscles, we have them activate the muscles against resistance, again, to try to recreate that pain.
Then you went into quite a bit of detail on Xrays. Talk a little bit about what you're looking for on Xray and why that's an important study.
Well, it was interesting. I was talking to Dr. Snyder about hip MRI after the meeting. And he's like, cartilage is so hard to see on a hip MRI. And it's true. Most of the cartilage is contained in the socket, or a lot of the cartilage is contained in the socket. So the MRI doesn't get a good view of what the cartilage looks like. It's a little different than the knee, where the MRI, like the tibia doesn't cover half the femur in a knee, and in a shoulder, the glenoid doesn't cover half the humeral head. So our foundation for hip treatment is the Xray, and I actually find that I get more information out of the Xray than the MRI. Not only the position of the bone, but the way that it's oriented, the amount of joint space that it has, the angle that the socket sits at, the amount of extra bone, cam deformity, or a pincer deformity. There are so many things that we can see on X-ray that the MRI isn't quite as useful for.
One other thing that you mentioned was the prevalence of hip pathology on MRI or imaging in a patient population that's healthy, that doesn't have symptoms. So when do you know how much a patient needs treatment? Because you mentioned that like an ACL tear is an ACL tear and probably needs to be fixed. But with hip problems, it's harder to know if surgery is needed. How do you make that decision?
Yeah, so it's a very interesting problem because we know that you can exist with a labrum tear and exist with a labrum tear for a really long time and either not know it or not have it affect you or not have it cause pain. So I think principally when we're talking about operating on labrum tears, we're treating pain. And I feel like we have a few important jobs. One is to determine that the labrum is actually causing the pain as kind of the first job. And the second job is to see if we can get that pain to go away without having to intervene surgically. And so those are kind of our two. And then maybe a third is to rule out other causes in addition to the labrum that might be contributing to the pain.
And one other question, this is in relation to a slide that was shown last week or the week before. If you were to take all comers at different ages and do MRI scans of their lumbar spine, they all have, depending on how old they are, problems seen on their MRI. And it sounds like the same is true to some extent if you were to look at all comers and look at their hip. Patients come in with low back pain. They've tried everything. And they know their MRI shows a problem. And I'm sure in your situation, patients come in with hip pain. They've tried everything. And they know from a report or some other radiographic study that they have a problem with their hip. And you look at it and you think, surgery is not going to help you. How do you have that conversation?
So I think one of the ways that we can begin to have the conversation is like with a diagnostic hip injection. So we try to do as best we can to re-examine them while they're still here. Because sometimes you'll do a hip injection, you'll ask the patient, hey, did that help you? And they're thinking back over the last 6 weeks, did it help me? And for the most part, no, because the numbing medication went away. So we try to re-examine them while they're still here in the office after we've injected them and numbed up their hip. And if they only have a partial response, they say, only a quarter of my pain it went away. I think it's easy to kind of explain to them, hey, well, we've numbed up your hip. If only a quarter of the pain went away, then we're probably having pain from a different source. On the other side, if 100% of the pain goes away, it's hard to argue that it isn't the hip. I think sometimes once patients hear that they have a tear somewhere, they associate that with like a major mechanical failure. And I think teaching them that a lot of patients have labrum tears and we find a similar thing in the meniscus where there's degenerative tears, but patients don't know it. We find the same thing in the shoulder with rotator cuff, partial and full thickness tears that the patient are just completely asymptomatic. So the body's pretty amazing at compensating or not sensing that pain. And for those patients, we want to get them back to that, kind of stable pain level if we can.
Thanks for presenting this morning. It's good to have understanding of spine and the rest of the musculoskeletal system, because there's a lot of similarities in the way the joints function. There's also some unique differences. And I think it's important clinically when you're evaluating patients to have a broad understanding of both. Otherwise, everything's a hip problem or everything's a spine problem, and you miss when it's really something else. And so, but appreciate you coming in and presenting.
Yeah.
And you're off to surgery now?
Yeah.
All right. Well, good luck.